Ko tēnei te reo mihi no te waipounamu atu ki a koutou kua tai mai nei. He mihi mahana tēnei ki te mana whenua tēnei whenua. Koutou e murumuru o koutou nei ahi. Nei rā te mihi mahana. Ko wai mātou, anei mātou nā kai rakahau no te waipounamu, arā ko te waka wauraki. Ko Justine toho kuikua, he uri ahau no kaitahu kāti māmoi wataha rapu ai. No te hapu o kāti rua hiki hiki, kāti moki tuarua, me kāti hui rapa ki poki tīraku. Ko Aotearoa parata me retara ka whānau, ko au tētahi mema o tēnei tīma. So kia ora koutou. Some of you have been thinking the dialect's a bit giggly. We had a wee bit of a giggle yesterday with the Taranaki one too. So bringing the K to you today, getting rid of all NGs, and yeah, bringing our mihi from there. So I'm just going to hand it over to the actual researchers who did the grunt and the mahi and all the fabulous analysis, and then I'm going to sort of wind up with where to next. So kia ora.
Cool. Do you want to see?
Oh, sure.
Well, kia ora tātou, ko Andrew Tokuikua, keeping those hard Ks going. Today we're going to be talking about a research trial that was done for people with type 2 and obesity who wanted to lose weight. So structurally this is looking at healthcare systems in Aotearoa, listening for where the problems and the need is, and then doing something to sort of maybe change and see what are our better options. Looking, listening, doing. The particular need for this trial came from patients at Te Kaika Health. Te Kaika Health is a Māori healthcare provider in South Dunedin. It's around 5,200 clients. And the patients there went to the clinical director and said, look, we're not happy with the current options for weight loss. You're telling us to eat less and move more, but that's not really helpful. You're not showing us anything. You're not giving us structure. You're not providing resources. So the clinical director was listening, which was great, and he came to the university and said, hey, I want you to do research. My patients need help, and I want you to help them. I don't care how you help them, but I want you to help them. That's quite a powerful thing for someone to come and say, here's the problem, show us the answer. So we were really excited to get some funding from Healthier Lives and the National Science Challenge to do a small trial looking at different weight loss, a particular weight loss option, working in Te Kaika Health with their clients on this project. The weight loss option that we looked at is called DiRECT, and it was sort of highlighted a year beforehand in a Healthier Lives cost of diabetes resource or report, and it looked at 5 different initiatives and had shown that the DiRECT weight loss trial was quite effective for weight loss. Here it started in the UK. If you see the green line, that's the body weight of people in usual care over 2 years. It's flat. They haven't gone up, they haven't really gone down. And then what they did is they compared those people getting usual care with people who got this DiRECT protocol. And you can see there with the red line, a sudden 3-month drop in body weight, and then over the rest of the 2 years, they've maintained the weight loss. That's fantastic. A lot of dieting stuff, you seem to yo-yo. You might lose some weight, but then you'll gain it back. These people lost it quickly, and they kept it off. And that's what DiRECT was doing. So DiRECT was so powerful, this initial result, it's now funded by the NHS in the UK. So if you have diabetes and you have obesity and you want to lose weight, you can go and get the support from them to do so, which is quite attractive. It's a viable option that other governments have funded. So we wanted to look at it here, and mainly what we wanted to look at was the acceptability. We figured that physiologically it could work, but are people actually going to do what the DiRECT protocol is? So the acceptability was our primary outcome, and we were powered. We had enough people to really look at acceptability. Kate Campbell is going to come up and present acceptability after this, but I'm going to give you the structure and show you some of the numbers, the weight loss and the other things that were achieved. We made quite a few changes to that initial UK study where we blew out and made the people in it far more generalisable. We didn't care if they had pre-diabetes or type 2. We didn't care how long they'd had diabetes for. And instead of just comparing it to usual care, because we figured that probably wouldn't help people lose weight, we compared DiRECT against dietetic support. So meeting with a dietitian weekly, then fortnightly, then monthly for a year to sort of get that healthy eating advice for that person to build up a relationship and then for them to help them specific to the needs of that person. So 2 pretty good comparisons, but we were still interested to see, will there be a difference between them? So structurally, it was a 12-month trial, and now I tell you what DiRECT is, and you start to think about it. The first 3 months is total diet replacement. So that kind of sounds scary, but have you ever seen OptiFast or OptiSlim, those sort of shake options? That's kind of what it is. We went with a provider who had the most flavours and textures available to us. They have porridges and soups. They had real meals like spaghetti bolognese, was my favourite. They had chocolate shakes and they had bars. But the concept is you have 4 of those a day. It gives you the nutrients you need, but not that much energy. That was what we asked our participants to do for 3 months. It's not an easy ask, and we'll hear more about how they went with it with Kate. But after that 3 months of total diet replacement, there was a food reintroduction. And this is really interesting because the stopping of food broke all habits they formerly had, so that reintroduction was very important to make sure they had the right foods in the right amounts going forwards. And then they stayed engaged with a dietitian for the rest of the 12 months. The people in the dietetic support group had the same dietitian, but instead of giving the DiRECT protocol, they gave them the best practice advice for eating and physical activity that we have. Everyone saw the same dietitian for the same number of times, 22 times over the 12 months. So good comparison, dietetics versus total diet replacement through DiRECT. It's a small study, we had 40 people. And Viliami, I recognise that Pacific is more than just one country. So for the numbers there of people in the Pacific, there was 4 countries represented. It was Samoan, then Tongan, Cook Islands, and then Tokelau. The 40 people, we had 20 in each group. 70% of our people were female. They were quite young, mean age in their 40s, BMI over 40. And largely because Takaika Health deals with Māori and Pacific, that's most of what our people came from. The others were Indian, and then Pakeha, and South African. We had just over 3/4 of our people had type 2, which means the other people had pre-diabetes, but they were still interested in joining the study because they wanted to lose weight. So how did they go eating their food? The blue line shows you the number of sachets per day, those sachets per day, for the first 3 months and then the last 9 months. Our advice was to have 4 a day, because it gives them all the nutrients they need, but not lots of energy. And they started off in that first 3 months having over 3 a day and less than 1 real meal a day on average. You see the food reintroduction, where they go off the sachets and they return to normal food. And you see afterwards, for the rest of the weight loss maintenance phase, they're having just under 3 meals a day on average and probably half a shake. So every second day they might have replaced a meal with a shake. Their choice. I think that's pretty good adherence. I'm surprised at how they did it, and Kate will talk more about that again. What did that look in terms of diet? Well, it didn't really change the amount of carbohydrate or protein or fat too much in the diet, but it did reduce a lot of how much energy they were having. So the people in the DiRECT started on around 8,700 kilojoules. At 3 months after that extreme period, they were having 4,000 less kilojoules a day. The people in the dietetic supported group, 8,100 kilojoules, they're having just over 1,000 less. So the difference was that they were consuming, people in the DiRECT were consuming 3,000 less kilojoules a day, which is a big chunk of food. What you see then is differences in body weight, because they're burning the energy of the food instead of storing it. So at 3 months, people in the DiRECT protocol had lost just under 7 kg, compared to the dietetic support, which was just under 1 kg. So the difference was 6 kg more for people in DiRECT. They lost 6 kg more after 3 months. Their blood pressure really did improve, that's systolic blood pressure, and they were taking less medications, but seeing better benefits. So that's 3 months, the most extreme bit. The other thing we did is, because they had pre-diabetes or type 2, we popped a CGM on their arm at baseline after 3 months of DiRECT and after 3 months of the usual care. And because we wanted to know what their blood glucoses were doing every day. Down the bottom, that's a day, so from midnight to midnight. And then on the other axis, that's their blood glucose levels circulating in their body. The black line, you can see, is at baseline for everyone. And they're spending around 75% of their day just too high, not in the healthy range from around, is it 6 a.m. onwards? They sort of go up and they stay high. If you look at the red line, that's after 3 months of dietetic support. And now it's around 50% of their time per day is spent in a good blood glucose level, normal blood glucose level, and 50% is too high. So that's a good improvement, full stop. But then if you look at after 3 months of DiRECT, you see that that blue line is almost always, on average, within a healthy blood glucose range. So what that means is less micro and macrovascular damage going on. Their body isn't sort of being damaged by high blood sugars. It's actually staying within the range that we hope to. So that was after the 3 months, which is our extreme period. But what about after the full year? Did people regain weight like a yo-yo, or did they actually stay down? I've only got the weight data because our people just finished less than 2 months ago. But what we saw is that the people in the DiRECT protocol, at 3 months they'd lost 6.9 kilos, at 12 months it was still 6.3 kilos. They've kept the weight off for the entire year, and that's a really good message by itself. The intervention effect, or the difference between the two groups, is a little bit less than before. That was 6 kilos before, and that's because that dietetic support kept on rolling for the whole year. And so those people initially at 3 months had lost 0.8 of a kilo, have now lost 2.2 as a group. So both arms are actually showing benefits. One's a more serious benefit and then maintained, where the other people are still seeing their dietitian and they're just tracking down, which is really, I thought, promising to see. So to end up my bit, we've conducted this small trial to look at this intervention that happened overseas to see if it's useful here. We played a little bit with the protocol to see how it might better play out in New Zealand, and our results indicate that it works. But the more important question is it acceptable here? And that's where I'm going to pass over to Kate to talk about that bit.
Kia ora koutou, ko Kate tōku ingoa. I'm from a little bit further north than Dunedin, so I've got the NG rather than the K sound there. So obviously we've got these numbers from our participants, which are really useful and interesting in telling us that DiRECT works, but it doesn't really tell us anything about people's actual experiences and how they found the intervention. And that's really important to us because we want to know how we can actually adapt DiRECT to use here in New Zealand for people who are affected by diabetes. And we've got research from overseas, from the original trial in the UK, that says DiRECT is acceptable, that people are happy to do it. But New Zealand isn't the UK. We're talking about a really different social and cultural context. And so we want to know what DiRECT means for people here. So I interviewed all of our participants in both groups at 3 months, so right after that total diet replacement phase for the DiRECT group, and then again at 12 months at the end of the study, and I'm sharing some findings from those interviews today. So in that first interview, we asked people to reflect on their experiences from before the study. And what they told us is that they really saw their health and their well-being in a really negative light previously. They said they'd tried to lose weight, often lots of times before, without any real success. They said they often felt judged for their body size and that they were really just confused and overwhelmed by all of the information that's out there about weight loss, about living a healthy lifestyle. Often their doctors had said you need to lose weight, but they'd been given no practical guidance on how to actually do that. So as you can imagine, a lot of them were feeling kind of desperate by the time they came to the study. And you can see that in that first quote, I knew I had to do something. There was a bit of hesitance about joining because people were worried about the judgment and stigma. Don't want some skinny person telling me I'm too fat. At the same time, there was some positivity, which was really nice as an interviewer. One participant, when he was asked about his reasons for joining, said all he was thinking was, well, what's the worst thing that can happen? So our participants really did see the study as an opportunity for positive change for their health and their body weight, their diabetes control, but also their lifestyles and well-being overall. So now I'll focus on just the experiences of that DiRECT intervention group, so that first phase of the study with total diet replacement. It was challenging, but surprising to me, they said it wasn't as hard as they'd expected, and a huge part of that was working with our dietitian to come up with strategies and solutions for challenges kind of just as they popped up. There were physical challenges. Being hungry was kind of an obvious one. There were also sometimes some side effects, but those tended to disappear within a couple of days. The mental challenge was really the biggest struggle for everyone. Getting used to having those really small portions, getting used to not having your real food, having a shake instead, for example, and also just trying not to sit there thinking about food when you knew you were on this diet. All of that was a lot to adapt to. There were also social challenges, so eating differently to your family, or maybe feeling like you couldn't sit down and eat with other people was also quite challenging. You could feel quite isolated. There were also some things that people really liked about the diet. It was really clearly structured, and it had a routine to follow, and it gave our participants a sense of control, which for some of them they hadn't ever had around food before. There was enough choice in terms of the flavours and the varieties of meal replacement products that they didn't get bored with the diet, and it was really convenient. The replacements were really easy to prepare, so they didn't have to worry about what they were having and how long it would take or anything like that. They also saw progress really quickly, so they started losing weight, and that was really motivating for them to keep going. But there were other benefits as well. They said they were sleeping better, their clothes were fitting differently, their skin was clearer, and all of that really helped them to stick to the diet that they were following. Summed up really nicely by this participant: you've got a plan, you see results quickly, and those results motivate you to keep going. And next for the participants was that phase of food reintroduction, so that kind of slow transition back to eating real food. And as you'd expect, that was quite exciting after 3 months on meal replacements, going back to having real food, feeling like you could eat with other people again. But it was also really daunting for a lot of people, and the big reason for that was because they were worried about losing that structure, that routine, and worried about whether they might lose control. And just like in the earlier phases of the study, having the support from the dietitian was just as important, if not more important, during food reintroduction. And after they transitioned back to real food was that ongoing phase of weight loss maintenance. And again, the dietitian was massively important because all of the challenges around food and eating that existed before the study were still there. They had to think about the cost of food. They had to go to the supermarket and be faced with all of these unhealthy options. And they had to decide for themselves what to eat and how much to eat. They really had to be adaptable and willing to kind of come up with solutions as these challenges popped up. For both of our groups, there were some really important social and cultural factors at play during this study, and they could be both positive and sometimes they could be quite a challenge as well. So social support was really important. Support from family, from friends was a really important motivator. But also what came through is that family was really important to our participants. So it was an individual study. We were working with single participants, but they saw the study as an opportunity to help their families as well, and that's something we needed to acknowledge. What also came through was just how important food and eating were for connection and interaction, especially for our Māori and Pacific participants. Oops, let me go back. Something's happening there. So coming together over food was really important, and this could kind of be a challenge for our participants because when they were making these changes, they were going against the kind of norms and expectations of the people around them, and people talked about coming up with their own strategies. So grabbing a plate at these events and making sure you held on to that before someone else could fill it up for you was really important, because then you didn't feel obligated to eat the food that you were given. And I think what this really highlights is that it was about the participant-led, whānau-led solutions, not about us as researchers saying this is what you need to do to solve these challenges. The dietitian was hugely important, but so was the participant. So they had to really work together to solve the challenges and the problems that popped up. So what was most important with the dietitian wasn't necessarily the practical advice, it was the relationship, and that's something that was talked about many times yesterday. It's real helpful not being judged. So they felt accepted, they felt safe, and that was helpful for them to continue. They also felt a real sense of personal responsibility. There was kind of this idea of, well, if I don't take on this advice, what's the point of me being here? Summed up really nicely here. It's always helpful when everyone in your house is on the same kaupapa. So By the end of the study, our participants were more conscious of what they were eating. They had recognised the importance of health for their family, and they said things like, "How has it made me feel? It's made me feel great about myself." They had come to realise that behaviour change and weight loss was a long-term process, and they developed this real sense of competence, of self-efficacy, this idea of, I can do this on my own now. And just for time, I will skip ahead a little bit and pass on to Justine to talk about where the wider implications of our research might be going. Thanks.
Hey. Okay, so what next? We want to take over the whole country and grow this. So we've put in an HRC application. Any of the board in the room, kia ora for some koha, that would be great. And we actually want to add in, I was going to say we're going to start pushing drugs, but it's possibly not the best appropriate way to say it. So we're actually going to add in this drug, which I think you take an injection once a week in your gut. I was really excited when I thought it was just a pill. I was going to try it myself. But yeah, so we're going to also compare a drug trial alongside these two. We're going to hit more. We've got quite a few relationships, most born in this room and via some others. And we're going to go bigger and better. You can just have a read later or something. But I guess our kaupapa and our underpinning philosophy is what's good for Māori is good for all. And that is why we've sort of started with our communities and why we're going to continue on with these communities. And as long as we get to put our little piece into achieving Māori order, then we know that we're doing our piece. How quick was that? And we just want to do our mihi and our thanks. So our clinician is at the top. Natalie was our dietitian. These are the research team. And kia ora, everybody. Was that it? Ka pai. Kia ora. Tēnā koutou, tēnā koutou, tēnā tātou katoa.